Welcome to this deep dive. Today, we are exploring a highly complex, often misunderstood, and frankly, sometimes taboo anatomical
We
zone.
really are. We're getting into the perineum and the vulva today.
Yeah, exactly. And we're pulling from a huge stack of sources for this. We've got clinical guidelines from the Royal College of Obstetricians and Gynecologists, surgical trials from SOAP.org, dermatological white papers from the Institute for Vaginal Health, and like massive data sets from the Swedish Diva portal.
It's a lot of ground to cover, but the data is just incredible.
It really is. So, our mission today for you, the listener, is to unpack the hard science of structural trauma, specifically childbirth, how this area actually heals, and the daily environmental factors that keep this delicate ecosystem thriving.
Right. Because it really is an ecosystem.
Okay, let's unpack this because while over 85% of women who have a vaginal birth suffer some degree of perineal trauma, it rarely gets discussed with the scientific rigor it deserves.
It really doesn't. And that is just a massive disservice to patients. Because the perineum, it isn't just regular skin that you can throw a bandage on.
Right.
It's a highly dynamic structural and environmental system. The way it heals or, fails to heal profoundly impacts a person's entire quality of life, from just basic physical comfort to their long-term psychological well-being.
I was actually trying to conceptualize this as I was reading through the clinical guidelines, and the best analogy I could come up with is like structural engineering.
Okay, I like that.
Right, because usually when we think of engineering, we picture a bridge, steel cables, concrete, a perfect balance of tension and compression.
Exactly.
And if a steel cable snaps during an earthquake, you just weld it back together. But with the perineum, it's like that bridge is completely covered in this delicate living moss that requires the exact right humidity and temperature to survive.
That is such a brilliant way to visualize it.
So when a major trauma hits, you aren't just repairing steel cables. You're trying to restore an entire fragile ecosystem without, destroying the moss in the process.
Yeah. You're dealing with immense tearing biomechanical forces right alongside a highly sensitive microenvironment. To truly understand how to heal this area, we really have to start with the underlying architecture.
Right. And looking at the anatomy, I kind of like to think of the perineal body as the grand central station of the pelvic floor.
Oh, absolutely. It's the hub.
Yeah, it's this central fibromuscular wedge located right between the vagina and the rectum. You have multiple crucial muscle groups like the levator ani and the external anal sphincter all just converging on this one central hub.
They act as the suspension cables for all the pelvic organs.
Exactly. So what actually happens to the physics of this hub when a baby's head comes through and it's stretched to its absolute biomechanical limit?
Well, the structural failure is categorized sequentially into 4 degrees, depending on just how much tension the tissue can handle before giving way. So a first-degree tear is superficial. The tension causes the perineal skin and the vaginal mucosa to split, but the muscles underneath remain totally intact.
Got it. So just the surface.
Right. A second-degree tear goes deeper, the mucosal layer fails, and the tear extends into those deep perineal muscles you mentioned. It compromises the structural wedge itself, but it stops short of the anal sphincter.
And most vaginal deliveries involve one of those first 2 degrees, right?
Usually, yes.
But the sources detail something much more severe, which is the obstetric anal sphincter injuries, or OASI.
Yeah, OASI. If the sheer downward force of the delivery overcomes the elasticity of the entire perineal body, the tear continues straight into the anal sphincter complex.
Oh, wow.
Yeah, that's a 3rd-degree tear.
Yeah.
And a 4th degree is the most catastrophic failure. That's a complex rupture that goes all the way through the sphincter and actually breaches the rectal mucosa.
Which sounds just incredibly traumatic to the structural integrity of the pelvic floor.
It is. It's a major event.
And historically, doctors tried to preempt this unpredictable tearing by just stepping in and cutting the tissue themselves, right? The episiotomy.
Exactly. For decades, routine episiotomies were standard practice. The guiding logic was that a clean surgical incision would be, easier to repair and heal better than a jagged natural tear.
Makes sense on paper, I guess.
Right. But the latest clinical guidelines from the RCOG show a massive paradigm shift based on long-term data. Routine episiotomies are no longer recommended.
Really? They completely shifted away from it.
Entirely. They are strictly reserved for urgent clinical indications now. Like, for example, if the fetal heart rate drops and the baby needs to be delivered immediately, or to make room for forceps during an instrumental delivery.
Okay, and what blew my mind in the research is that when an episiotomy is performed today, the geometry of the cut is calculated with intense mathematical precision. It's not just a quick snip.
Oh, not at all. The guidelines are highly specific, specifically to minimize the risk of the cut extending into a severe third or fourth degree OASI. The standard is a medial lateral cut. The surgeon must position the scissors at exactly 7 o'clock on the vaginal opening. The incision has to extend 3 to 4 centimeters outward toward the ischial tuberosity.
Which is the sit bone, right?
Exactly, the sit bone. And most importantly, the angle of the cut must be between 40 and 60 degrees.
Wait, let me make sure I understand the physics there. The 40 to 60 degree angle, that's specifically to direct the tearing forces away from the rectum as the head passes through.
Precisely. If the angle is too shallow, like closer to the midline, the tension of the crowning head will just propagate the surgical cut straight down into the anal sphincter anyway.
Causing the exact catastrophic injury they were trying to avoid.
Right. But whether the trauma is a natural muscular tear or a mathematically precise surgical episiotomy, this raises an important question.
Which is how to fix it.
Exactly. How do clinicians best put this structural hub back together to ensure it functions normally again?
Well, here's where it gets really interesting. Because the traditional wisdom has always been to just, break out the needle and thread. You sew the tissue back together to recreate the tension.
That's the standard, yes.
But we have a randomized control trial in our stack from strip.org that completely challenges that assumption.
I love this study.
It's wild. They took women who had episiotomies and compared the traditional repair method, which is continuous non-locking stitches using a material called Vicryl Rapid, against skin adhesive tape.
Literally steri-strips.
Right. I have to admit, reading this, I was incredibly skeptical. You're telling me they use what is essentially medical Scotch tape on one of the most high-tension, heavily bleeding muscle groups in the human body.
It sounds totally crazy.
Like, how does that not just instantly burst open the second the patient sits down?
It sounds entirely counterintuitive. But to clarify the surgical mechanics a bit, the deep muscle layers in a severe tear still require some internal suturing.
Okay, so they do sew the deep stuff.
Right, to restore the core structural integrity. But the trial focused on the superficial repair, the skin and mucosal layers. And the data on replacing surface sutures with adhesive tape is incredibly compelling.
Yeah, the pain reduction was huge, right?
Massive. The trial tracked patients' postpartum pain levels meticulously. The women in the adhesive tape group reported significantly less pain at the 4 and 6 hour marks, and that pain reduction persisted continuously through days 3 to 7.
That is a crucial window of time for a new mother. But why does sewing the surface cause so much more pain than taping it?
It comes down to cellular biology and the body's immune cascade. When you use sutures, you are physically puncturing delicate tissue repeatedly and introducing a foreign body, the thread itself.
And the body doesn't like that.
Not at all. The immune system immediately detects that foreign material and triggers a massive macrophage response. Macrophages are white blood cells that rush to the site to break down perceived threats.
Right.
To get there, they release histamines that cause local blood vessels to dilate and leak fluid into the tissue.
So the body is essentially attacking the stitches.
Exactly. That fluid influx causes edema, which is swelling, and the increased blood flow causes erythema, or redness.
So it's an inflammatory reaction.
The sutures literally create a secondary, highly localized inflammatory event right on top of the original trauma. The resulting swelling puts immense pressure on the local nerve endings, which translates to severe pain for the patient.
While the tape just holds the edges together topically without setting off those immune alarms, that totally makes sense.
It's much gentler on the tissue.
But there has to be a catch. What happens if the tape fails or the edges don't perfectly align?
There is a significant trade-off with conservative management. If the wound gapes open, the body has to fill that structural void from the bottom up through a process called granulation.
Granulation tissue.
Yes, granulation tissue is rich in new blood vessels, but it's fundamentally different from the original mucosa.
It's that raised, red, bumpy tissue you see on a deep scrape when it's like overhealing.
Right. And in the perineum, excessive granulation tissue is a serious problem. It lacks the natural elasticity of the surrounding mucosa. It matures into a rigid, misshapen scar.
Which doesn't stretch.
Because it can't stretch, it often leads to severe dyspareunia, making sexual intercourse incredibly painful months or even years down the line. So the clinician is walking a tightrope.
Trying to balance the two approaches.
Exactly. minimizing foreign body inflammation to reduce immediate pain while ensuring the edges are perfectly approximated to prevent rigid scar tissue.
The stakes of that tightrope walk are incredibly high. Because how this grand central station is repaired in those first few hours dictates the patient's physical and psychological reality indefinitely.
It really does.
I was struck by the qualitative studies in our sources. They identified core themes in how women describe their lives after severe perineal trauma. They didn't just talk about physical pain.
No, it goes much deeper than that.
Yeah, they used phrases like feeling like the abandoned mother, experiencing a fractured fairy tale, and having to navigate a completely different normal.
The psychological weight just cannot be overstated. When your core structural suspension system is compromised, basic existence becomes a challenge.
Just existing is hard.
Women report being unable to stand long enough to hold their baby, being terrified to use the bathroom, and feeling completely disconnected from their own bodies.
Let's dig into the physical mechanics of that disconnection, because the data from the Swedish Diva Portal study really highlights how specific repairs dictate outcomes.
Yes, that study is fascinating.
They followed women 1 year postpartum to see how the type of tear impacted their body image.
And the findings reveal a lot about the limitations of surgical repair. They found that women who had episiotomies had the highest risk of perceiving their vagina as too wide and suffering from a negative body image a year later.
Which is heartbreaking.
An episiotomy is a deep, straight cut that cleanly severs the muscle fibers. If those fibers aren't sutured back together with exact anatomical alignment, the muscle heals with a gap.
Which leads to structural laxity.
A permanent structural laxity, yes.
Yeah, that makes logical sense. A deep cut might heal too loose. But the study also noted that women with minor second-degree tears often felt their vaginal opening was too narrow.
Yes.
I really struggled to wrap my head around that. Why would a relatively minor natural tear make the tissue tighter than it was before?
It's a classic iatrogenic effect, meaning the complication is actually caused by the medical intervention itself.
Oh, wow.
Imagine a surgeon or midwife repairing a minor tear. They know the risks of gaping wounds and granulation tissue we just discussed. In their anxiety to ensure the wound is securely closed, there's a psychological tendency to overcompensate.
So they pull it too tight.
They might use too many sutures, or they inadvertently pull the mucosal layers too tightly together. They succeed in closing the wound, but they artificially constrict the introitus, the vaginal opening.
So it's a structural Goldilocks nightmare.
Yep.
Too loose, and the pelvic floor is unsupported. Too tight, and you have chronic pain from artificial constriction.
Exactly.
What happens when a patient is stuck with a poorly healed repair? The sources mentioned perineoplasty.
Yes. Perineoplasty is a surgical reconstruction. If the muscle healed asymmetrically, or if rigid granulation tissue is causing chronic dyspareunia, a surgeon will go back in.
Sounds intense.
It is. They meticulously excise the poorly healed scar tissue, locate the retracted ends of the severed muscles, and rebuild the fibromuscular wedge to restore proper anatomical support and elasticity.
Now wait, so I want to ask about something specific here and just connect a couple of dots from our sources.
Sure.
Specifically regarding an episiotomy that heals with a gap. This is where the structural engineering directly crashes into the ecosystem analogy. Can structural changes to the perineal body, like after a poorly healed episiotomy clip, can that actually create an asymmetric gap that accelerates surface moisture evaporation?
That is a phenomenal connection to make. Yes, absolutely.
Yeah. Wow, okay.
If the vaginal opening is gaping asymmetrically, it often leads to a symptom called vaginal wind, where ambient air gets trapped inside the vaginal canal. But more importantly, it means the inner delicate mucosal tissues are chronically exposed to the outside air.
And those inner tissues aren't designed for constant air exposure.
Exactly. The inner vestibule is non-keratinized. It lacks the tough, waterproof outer layer of dead skin cells that protects your arm or your leg.
Right.
If a structural gap exposes that delicate mucosa to ambient air, it dramatically accelerates surface moisture evaporation. You get a massive spike in what dermatologists call transepidermal water loss, or TEWL.
So the moisture just vanishes.
Yes. The tissue rapidly dehydrates, becomes irritated, and the entire local microclimate is destabilized.
So a purely physical structural failure literally causes an environmental collapse on the cellular level.
Precisely. Which is the perfect way to transition, because if we connect this to the bigger picture, we have to look closely at the vulvar microclimate itself.
Yes, let's talk about the weather.
We've spent all this time on the deep structural muscles, but the external surface layer, the weather on the skin as you called it, dictates day-to-day health just as much.
The weather on the skin. The National Pressure Injury Advisory Panel, the NPUAP, defines microclimate as the specific temperature and humidity at the skin interface.
Right.
The Agility white paper gave this great analogy to visualize why this matters. Think about being in a swimming pool for 2 hours. Your fingertips get entirely wrinkled and waterlogged.
Right. The skin becomes macerated.
Exactly. When the skin is overhydrated like that, it gets spongy. And more importantly, it becomes highly vulnerable to physical stress.
Like friction.
Yeah, if you scrape your waterlogged hand against the side of the pool, the skin just peels right off. It falls apart under friction and shearing forces.
And that biomechanical vulnerability is exactly what happens to the vulva when the microclimate is disrupted. The vulva naturally maintains a higher humidity and temperature than exposed skin, but it exists within a very narrow optimal range.
Not too much is bad.
If you trap excess heat and moisture against it, you hyperhydrate the tissue. It becomes macerated and spongy, making it incredibly prone to microscopic tears from basic movement, which immediately invites infection.
Which brings us to a highly relevant everyday scenario. The panty liner study from the Acta Dermatovenerologica journal.
Yes, very important study.
Because millions of women wear panty liners daily to deal with discharge or, precisely the kind of moisture issues we just talked about. But if the skin is that sensitive to trapped moisture, what happens when you seal it off with plastic?
The thermodynamic data was stark. When participants wore a conventional panty liner, one manufactured with a standard, non-breathable plastic back sheet, their vulvar skin temperature rose to 35.9 degrees Celsius.
Okay, and the baseline?
For context, wearing no liner at all kept the skin at a naturally cooler 34.4 degrees.
1.5 degrees Celsius might sound negligible to us walking around outside, but to a microscopic ecosystem, that is catastrophic global warming.
It really is. And the temperature spike wasn't even the most destructive part. It was the chemical shift.
Oh, right, the pH.
With no liner, the skin pH was around 5.2, which is nicely acidic. With the conventional plastic liner trapping the heat and moisture, the pH shot up to 5.8.
And we know from the Institute for Vaginal Health that maintaining an acidic environment is non-negotiable. The acid mantle is the chemical shield that keeps the good bacteria, specifically lactobacillus, alive.
Yes, lactobacillus is essential.
It produces lactic acid to keep the pH low. So if the temperature rises and the pH goes up to 5.8, the lactobacillus is suppressed, and harmful pathogens and yeast just thrive.
Exactly. The plastic liner effectively suffocates the acid mantle. Now, the study did note that when women wore breathable liners, ones engineered with microporous films that allow vapor to escape, the temperature and pH remained almost identical to wearing nothing at all.
So the specific materials resting against this microclimate completely govern its survival.
Absolutely.
So what does this all mean for someone just trying to maintain their daily hygiene? If this microclimate is so incredibly sensitive that a piece of plastic backing on a liner can trigger an overgrowth of pathogens, how on earth should a person be cleaning it?
It's a great question.
Because the conventional wisdom, like the advice you hear from almost everyone, is just use water. Don't use soap, just use water. But our sources explicitly call this a myth, which honestly threw me.
It is a pervasive myth, and it stems from a good intention, the desire to avoid harsh chemicals on sensitive tissue. But it fundamentally ignores the unique biophysics of the vulva.
How so?
As we mentioned, parts of the vulvar epithelium lack a thick, keratinized layer. It is highly permeable.
But if it's highly permeable, shouldn't water just soak in and hydrate it? Why is pure water bad?
It's counterintuitive, but washing with plain water actually induces severe dehydration. The Institute for Vaginal Health explains that repeated rinsing with just water depletes the essential intercellular lipids.
The natural fats that seal the skin barrier.
Yes. Remember that transepidermal water loss. When you wash away those lipids with pure water, moisture from the deep tissue rapidly evaporates out.
Yeah.
The water strips the barrier, evaporates, and leaves the tissue severely dehydrated and prone to microcracking.
Okay, so water strips the protective lipids. But traditional soap is terrible too, right? Because of the pH.
Yes, traditional soap is made through a chemical process called saponification, which naturally results in a very high alkaline pH, often over 9.
Wow, okay.
If you put a pH 9 soap on an ecosystem that desperately needs to stay between 4.5 and 5, you are chemically obliterating the acid mantle. You destroy the lactobacillus and roll out a red carpet for infection.
So you can't use just water because it dehydrates the tissue, and you can't use soap because it destroys the acid mantle. What is the actual solution?
What's fascinating here is that dermatologists and gynecologists have established a clinical gold standard, and it's called a Ascendant.
Syndet, synthetic detergent.
Exactly. Syndic cleansers are meticulously engineered, soap-free formulas. Instead of harsh saponified fats, they use mild, non-ionic surfactants.
Okay, so a totally different chemical makeup.
Right. These molecules are designed to gently bind to dirt and sweat and rinse them away without dissolving the skin's essential lipids.
That's incredible.
And most importantly, Syndents are chemically pH balanced to match the vulva. They clean the area while actively maintaining that crucial acidic microclimate. It is precision engineering for skin hygiene.
It really all comes back to precision engineering. Let's zoom out and summarize this incredible ecosystem. The perineum and the vulva are dual-layered marvels of biology.
They really are.
You have the deep structural architecture, the grand central station, which requires exact mathematical care to heal properly after the immense biomechanical trauma of childbirth.
And we learned that the immune response is so powerful that sometimes adhesive tape actually outperforms sutures for pain management.
But clinicians must carefully balance that against the risk of rigid granulation tissue and dyspareunia.
Right. And we saw how structural failures, like an asymmetric episiotomy gap, create an environmental cascade, trapping ambient air and causing massive transepidermal water loss that dries out the internal mucosa.
Right. Structure directly dictates environment. And sitting on top of that architecture is the microclimate, a landscape that demands the perfect temperature, optimal humidity, and an acidic pH to maintain its bacterial shield.
Yes.
It is an ecosystem that can be thrown into total chaos by something as seemingly harmless as a non-breathable panty liner or just a splash of highly alkaline soap.
It demands an incredibly high level of biological respect.
It absolutely does. And to you, listening to this, whether you are applying this knowledge to your own body, supporting a partner through the grueling process of postpartum recovery, or you just love understanding the hidden mechanics of human anatomy, knowing this science is a massive step toward better overall health.
Couldn't agree more.
We need to stop treating this vital area with a mix of taboo and guesswork.
I completely agree. And I'd like to leave you with one final thought to ponder.
Let's hear it.
Our sources noted how aging, estrogen loss, and daily friction can thin this delicate tissue and alter its microclimate. Think about the massive shifts in our modern lifestyle.
Oh, right.
We have seen a huge rise in prolonged sitting. People locked into sedentary desk jobs for 8 to 10 hours a day. Combine that with the ubiquitous daily wearing of tight, non-breathable athleisure wear, like yoga pants.
Oh, wow.
Consider how those two constant environmental pressures might be silently, slowly compounding these microclimate disruptions and weakening the pelvic floor over a lifetime, entirely independent of childbirth.
That is a wild thought. We might be engineering our own ecosystem collapse just by sitting at our desks in the wrong fabrics.
It's definitely something to think about.
Because at the end of the day, you can't just weld a snapped cable and walk away. If you don't take care of the moss, the humidity, and the environment, well, the whole Brit is going to fall apart. Thanks for joining us on this deep dive. See you next time.